But today she's going to be talking about his other legacy, and that is the two-stage placental model preeclampsia. And one of the things I'd just like to say is that when I started seeing Annetine working with Chris, I could see that she again enlightened and lit him up again and got him excited about the whole work that she's doing and the collaboration that he had with her. So it's a great pleasure to ask her to talk about his legacy of the two-stage placental model of preeclampsia. Over to you, Annetine.
Thank you so much, Jimmy. Can you see my total slide now?
We can see your slides, yeah.
Yeah, so it's correctly presented, not only the, okay. Thank you so much. So it's a great pleasure to be here today. It's an honor. And I'm really impressed by the work APEC is doing. I mean, you have a really global impact. I met in Ghana last year, a woman from APEC Ghana. And that was so important for me to see that you're reaching all around the world. And also today's presentations have been great. So it's a great honor to present some of Chris's work and legacy. And as Jimmy said, also to me, he was a fantastic collaborator, a friend, and a mentor, not only for me, but also for my research group in Oslo. As you can see, Chris visited many times, and we went on many hikes together. And some of the most interesting discussions we had did evolve around the pathophysiology of preeclampsia. And Chris had a brilliant mind, and his ability to integrate new knowledge into new concept was unique. And I was very fortunate for being included in the discussion and revising this two-stage preeclampsia model and to learn from the very best in the field. And when I'm presenting to you now, I'll go back in time. And of course, my presentation will be quite superficial and not as granulated and sophisticated as Chris's research was. So if this is moving to the next slide now, it's not. I'm having a little problem here. Jimmy, how do I do? That's working now. So in 1991, Chris came with the groundbreaking paper in Placenta, presenting the two-stage model of preeclampsia. And he based his model on what was known at that time. Most people talk about preeclampsia like any other hypertension. But Robertson and colleagues showed already in 1967 that there was indeed poor placentation with shallow remodeling mutual placental arteries that was present in preeclampsia, a placental problem. Later on, we knew that that was just present in early onset disease, not in the late onset. And also Jim Roberts, his good friend from America, he published in 1989 that preeclampsia was an endothelial dysfunction disorder. And Chris, of course, had much of his own research, but he then kind of integrated these two findings. So he showed that how the stage 1 was the preclinical one with dysfunctional placenta that became hypoxia due to the poor placentation and the abnormal development of the uteroplacental circulation. This resulted in deportation of inflammatory factors over to the maternal circulation, which again would give rise to what we know as the clinical signs of preeclampsia, the stage 2, which happens later in pregnancy with hypertension, proteinuria, and eclampsia. And as Chris wrote in his paper, he said that stage 2 was a sequel of placental ischemia, secondary to spiral artery insufficiency. So this was, to us, it seems quite logical today, but that was not the case when he presented this model. And then he made several refinements of his two-stage model. And this paper from 1999 explains how maternal risk factors promoted development for stage 2. So this paper showed that any woman would go from a low systemic vascular inflammation outside pregnancy towards more inflammation in normal pregnancy and excessive vascular inflammation in preeclampsia. So it argued that maternal endothelial dysfunction is a part of the more generalized vascular inflammatory response of preeclampsia, and that this is not an epiphenomenon, but it represents actually the cause of the preeclampsia clinical syndrome. And then maternal diseases that involved ongoing vascular inflammation were suggested to lower the threshold for the inflammatory effects of pregnancy. So, for instance, women with diabetes, obesity, and chronic hypertension, and some autoimmune disorders would start higher up on this inflammatory ladder and therefore more easily develop preeclampsia even without an abnormal placentation. So he argued that poor placentation is not the cause of preeclampsia, but a strong predisposing factor, and that no single preeclampsia gene, no single specific predictive test, nor single effective measure will be devised due to the heterogeneity of the syndrome. Of course, we hope is wrong, but until now, that hasn't been proven. So several other refinements were done. So this is the classical step that shows the early onset type of preeclampsia. And we discussed more and more after I started working with him after his retirement that perhaps it was the placenta itself, the outer cell layer, the multinucleated syncytiotrophoblasts that was the real problematic organ. So we called it syncytiotrophblast stress rather than just placental dysfunction in stage 1 of preeclampsia. And of course, we came back over and over again, how can we explain late onset preeclampsia with this model? And then we moved into, could there be other causes of placental malperfusion and syncytiotrophblast stress other than poor remodeling of the spiral arteries, like in early onset preeclampsia? And then later on, of course, came the papers on the angiogenic factors from Anand Karmanchi and Richard Levine, giving us examples of how stage 1 and stage 2 are linked together. And we used this angiogenic factors knowledge in our paper from 2013, together with the CoLab group of researchers, to say that, well, among those women who have poor placentation, we are going to find low PLGF due to the syncytiotrophblast stress, which gives more soluble fluid to the maternal circulation and lower PLGF level. Whereas in women with a normal placentation, they will not have a low PLGF early in pregnancy. So we kind of redefine preeclampsia according to those placenta-derived biomarkers. But as we came back to over and over again, is there really something called maternal preeclampsia? Is there really a preeclampsia without placenta? Because no other persons than pregnant women or recently pregnant women can have preeclampsia, and no man in the world has ever developed preeclampsia, even if they have risk factors. So then in 2014, we moved on to a multi-stage model, and this was based on our work together on uteroplacental acute atherosis. These are lesions that are found in the spiral arteries leading into the placenta, and they resemble early stages of atherosclerosis, the fatty streaks. And we found those lesions very often in preeclampsia, about 50%, and we have a lot of work on that in our Oslo Pregnancy Biobank publications. So we then said that there were pre-placentation factors that could affect this placentation problem, leading to the dysfunctional placental function with oxidative stress, endoplasmic reticulum stress, and inflammatory stress, which again then causes the excessive vascular inflammation of the woman, giving her the clinical signs of preeclampsia, and also then leading to more risk of developing those inflammatory lesions, the acute atherosis lesions, which again could feed back. So we had many interesting discussion around this as well. So this model included then pre-placentation factors leading to poor placentation and suggesting uteroplacental acute atherosis integrated in the inflammatory process. Because of at that time, of course, we knew a lot more about the inflammatory and immunological pathway and the poor tolerization data on the risk of preeclampsia. So again, we came back to the question, does the age of the placenta play a role for the late onset preeclampsia type, where there's no poor placentation? And Chris was expert in finding good documentation. This is a book from Kaufman showing that, yes, indeed, the growth of the placenta villi increases a lot towards term, whereas the distance between the villi in the placenta actually is decreasing more and more and is really crowded at the end of the pregnancy near term. And this is what Chris then called the pot-bound placenta, because just as a pot where you have your plant cannot expand forever, uterus cannot grow forever, so it will really crowded between the villi towards term. And this is what you can see here in the paper from Konye, that there is less and less space between the villi at the end of the pregnancy. Now, as Chris also said that, well, is it really true that late onset preeclampsia has a null placenta? Because there are many markers of syncytiotrophblast stress in preeclampsia, and most of them are not documented by routine clinical pathology. And for instance, syncytial knots, it's also a feature of late pregnancy and term and post-term pregnancies. And also the work by his friend Graham Burton and Bill Young on endoplasmic reticulum stress and the unfolded protein response was also part of what we saw as a syncytiotrophblast stress problem. And then came the papers, as I said, from Richard Levine and Anand Karmanchi from 2004, showing us that PLGF, placenta growth factor, and soluble FLT1 were indeed produced by the placenta, and we saw them as biomarkers of syncytiotrophblast stress. Because if you look at the pattern, the PLGF will increase towards 30 weeks of pregnancy, then decrease in normal pregnancies, whereas S-FLIT is relatively stable until it increases by the end of the pregnancy. Whereas, as you all know, in preeclampsia, there is a high soluble FLIT level and a low PLGF level in the maternal circulation. So when we are looking at the term and more over to postterm pregnancy, we see that the angiogenic pattern becomes more like preeclampsia. So we take that as an evidence for syncytial stress by the end of even normal pregnancies. And this is also what we see clinically, that there is an increased risk of preeclampsia the more term and postterm you come. This was also shown earlier today that if you induce women early, they will not develop preeclampsia. And we have also done several papers together with Chris on these angiogenic biomarkers in our postterm population also that remained clinically healthy, but still had an anti-angiogenic vascular or biomarker pattern. So Chris called this late preeclampsia like a result of the twilight placenta, that an old placenta is hypoxically stressed, it loses function, it's increasing soluble FLIT and reducing PLGF in the maternal circulation as markers of that, and the placenta is struggling to sustain a growing fetus, which competes for space and oxygen. So what happens first? Is it delivery or is it a clinical problem? So we're back to the competing odds. So according to that, all women will get preeclampsia eventually, but of course most women deliver first. And this is also then modeled in the paper by Wright, that at the top here, a low-risk woman would get preeclampsia at a median time of 56 weeks, where most women are not pregnant anymore, whereas high-risk women get preeclampsia before they deliver. So it's about the race, as Chris said. Pregnancy is a race. The finish line is the delivery. So what gets there first? Is it preeclampsia? Is it spontaneous labor? Or do we induce before we get to preeclampsia? And can we thereby also avoid the dark horse, which of course is intrauterine fetal death? Now we continue to evolve this model, and this is a paper from 2022 that I think was shown before today as well, where we now said more about what are the processes going on in syncytial stress, not only oxidative stress, it's not only hypoxia, but ER stress, mitochondrial stress, apoptosis, autophagy, and so on. And that this was typically of early onset with early placental malperfusion, whereas the late onset preeclampsia would typically have a normal placentation, that's what we know from pathology samples, but that we predicted that the pot-bound placenta, the villus crowding, would give intraplacental malperfusion. That means malperfusion and syncytial stress of another cause and timing than you see in early onset preeclampsia. This is what we see in late onset, where there rarely is fetal growth restriction. And of course, there are mixes of these two extremes. So that's the twilight placenta story. So as I see it, if you have a good model, your risk factors should fit with that model. And Chris says it's the opposite, Antine. It's the model that's made after risk factors and the clinical heterogeneity. But the risk factors should in this model work on the placentation problem, on the placental function, or even on the maternal cardiovascular response to placenta shed stress factors. And to me and to Chris, this fits very well with first pregnancy being a risk factor, multiple pregnancies with big placentas giving then intervillus malperfusion problems, chronic hypertension giving maternal vascular problems and also placentation problems, renal disease, high body mass index, high age, and diabetes. And also, I don't think there are any models made later on that actually can explain all these features. Because how can you explain if the heart was the problem, that first pregnancy and the timing between the pregnancies matters, if it was not for immunological problems and effect on placentation. And even on smoking, we know that smoking reduces the level of soluble FLIT, but still we get a really fetal growth restricted fetus, which also fits with the model. So when I explained to my students this two-step theory of a concept of preeclampsia, I said that, well, immunology lies behind the poor placentation often, and this can explain then how first pregnancy is a problem, a risk for preeclampsia, as is short sexual cohabitation time with that partner before this pregnancy, and also issues of egg donation. This is, of course, very superficially explained, but that's how I teach my students. And then I explain the late onset preeclampsia as an other problem, not a remodeling and placentation problem, but an intervillus malperfusion later in pregnancy because of a pot-bound placenta. And even if late onset preeclampsia is not as critical for the fetus, it's still a major problem across the world, which you heard earlier today, affecting 2/3 of pregnancies in our part of the world. And we have lots of health cases and eclampsia also in late onset preeclampsia women. So the classical would be uteroplacental malperfusion, and the then late onset preeclampsia would be due to intervillous malperfusion. So, and as it's important to acknowledge that maternal risk factors are very important, both for both these pathways. As we saw in our intergrowth data, we saw that obesity both increased the risk for early onset as for late onset preeclampsia in adjusted analysis, which makes sense because big women make big placentas, have risk for congested placentas, but they also have risk for poor placentation. And the same way, we know that, for instance, obesity affects also the vascular inflammation and presets it, so it will be more sensitized to whatever comes of pro-inflammatory factors from the stressed placenta. So in this way, I think this model explained most of the features we're seeing today. So now I move on to what we're doing today in my group. We are working using this two-stage model in something called fetal microchimerism studies. And this was also done together with Chris starting 10 years ago when we started working more on acute atherosclerosis. But as you probably all know, in any pregnancy, there are fetal cells coming over from the fetus to the mother through the placenta and from the mother to the fetus. And in the mother, we can find these fetal cells decades later on until the rest of her life, and in many, many of her organs, such as the brain, blood cells, heart, and liver. And we think they are pluripotent cells. And we call it fetal because we talk about fetal cells that are functional, and micro because there are so few of these fetal cells compared to the amount of maternal cells. And we call it chimera or chimerism because, as you see in this Greek mythology picture of a goat and a lion and a snake, the mother is no longer just her own genome, but also consists of her offspring and perhaps her previous offsprings and even her mother's cells. So we knew from before we started our work that some smaller studies had shown that fetal cells in the mother was indeed increased in women with preeclampsia versus healthy controls. And if they were present, there were more of them. But we also saw that this was also a feature of fetal growth restriction and diabetes and with increasing gestational age. So our hypothesis was, could it be that placental dysfunction, namely the stage 1, in itself impacts fetal cell transport over to the mother during pregnancy, thereby not a diagnosis, but a biological phenomenon. And so we use this two-stage model showing that stage 1 is placental dysfunction, stage 2 is the clinical signs of preeclampsia, and that all pregnancies go towards senescence in the placenta, therefore go towards the stage 2. And that the pathways leading to stage 1 could be numerous, such as this shallow placentation with placental malperfusion, typical early onset preeclampsia leading to syncytial stress, and then stage 2. And also this, as I said, the late onset preeclampsia type with the pot-bound placenta. But we also suggested a third variant, namely placenta senescence of many causes, and perhaps even placental malperfusion causes more senescence earlier in placentas. And this would lead then to, as I said before, syncytial stress, leading to more pro-inflammatory factors over to the mother, where we can measure the placental stress by low PLGF and high soluble FLIT. And that again sensitizes the maternal vasculature and gives her the typical signs of preeclampsia. So we said that we have to acknowledge predisposing maternal factors affecting all the placentation and stage 1 steps, as well as the maternal receptivity for the stress factors coming from placenta. And then our new hypothesis was that could it be that this syncytial stress also coincides with more fetal cells over to the mother that again can stress the vasculature, but also stress the placenta so that you have a feedback loop. And to make a long story very short, we were able to do in some hundreds of our patients from our Oslo Pregnancy Biobank group that we have followed up for several years, where we can follow not only fetal cells from a male fetus, but both from males and females by looking for the allele that is present in the fetus, but not in the mother, that is inherited from the father. And this is the PhD thesis of Heidi Fjeldstad that did her dissertation last month. So we showed indeed that the presence of fetal microchimerism and the amount of fetal cells during pregnancy in the mother did correlate with placental function. we could have several proxies for that, either birth weight percentiles, but also low PLGF and high soluble FLIT. And the interesting thing was that this was a feature not only of hypertensive pregnancies, but also in normotensive and diabetic pregnancies. And we showed also that women with diabetes, they have also with poor glucose control, they also had more fetal microchimerisms in the mother after adjusting for placental function. And then lastly, we showed that women with severe maternal hypertension in hypertensive pregnancies, such as preeclampsia, after adjusting for placental function and glucose control, these women also had a more fetal microchimerism. So I hope I now have convinced you that this two-stage placental model of preeclampsia helps to understand the features of the heterogeneous preeclampsia syndrome. It fits with clinical, epidemiological, and biomarker findings of the syndrome, and it explains risk factors for preeclampsia. So we have this uteroplacental malperfusion leading to syncytial stress, the stage 1, and the intervillous malperfusion also leading to syncytial stress, but from another reason and later on in pregnancy, in late onset preeclampsia. And that maternal factors may affect both placentation and placental function pathways, as well as, importantly, the receptivity of the maternal vasculature on the placenta stress signals coming from the placenta. And I also hope that show you that this two-stage model is helpful for contextualization in research on obstetric syndromes with placental dysfunction, not only restricted to preeclampsia, showing that stage 1 indeed associated with more fetal cells in the mother that lives on for many years, as well as hypertension per se, after adjusting for placental factors, also associated with how many cells the mother receives from the fetus. And the second part of our fetal microchimerism study is to see, do these fetal microchimerisms with a different genome than the mother herself has actually also increase the risk for vascular inflammation, macro and micro vascular diseases, and the increased risk of cardiovascular disease we see after preeclampsia. So thank you so much for listening. Thank you to my research group and collaborators, and not at least, thanks to Chris for being such a great inspirator to us all. Thank you.
Thank you very much, Annetine.